Hello, and thank you so much for the invitation to speak to you. I wish I could be there in person, but appreciate the opportunity to give a lecture on clear cell and mucinous adenocarcinomas of the gynecologic tract. My name is Akila Viswanathan. I'm the professor and director or chair of the Department of Radiation Oncology and Molecular Radiation Sciences at Johns Hopkins University School of Medicine in Baltimore, Maryland. My disclosures: I work for Johns Hopkins. I am the editor-in-chief of Seminars in Radiation Oncology for Elsevier, NCI Uterine Task Force Chair, and on the Uterine Clinical Trials Planning Committee. And I have to say, I will disclose I'm a radiation oncologist. So this talk will have certain biases based on my knowledge as a radiation. So clear cell carcinoma, what is it? Well, histologically, it's characterized as shown on the slide on the right with these vacuolated hobnail type cells that have large mucin deposits that give them this very stereotypical appearance. Clear cell carcinomas arise in many different organs, from renal cell to ovarian. As radiation oncologists, we see it more commonly in uterine, cervical, vaginal, or vulvar cancer. Now, in terms of risk factors, there are very few that are actually known. It's a rare cancer, and so there's not much epidemiologic information. But we do know that DES, or diethylpyridine exposure in women who are pregnant, and this was a medication given in the 1960s against nausea. Their female children had a higher risk of vaginal, cervical, or uterine clear cell carcinomas. It represents about 1 to 5% of all endometrial cancer and has this classic appearance, as I mentioned, with solid papillary or tubulocystic structures. Generally, it has a low mitotic index, but that can be variable, and it can be present in all types of high-grade endometrial carcinomas. 80% have myometrial invasion and has a poor prognosis. Overall, these are considered resistant. They're more resistant to chemotherapy than radiation therapy, and so radiation has become a hallmark in the treatment of clear cell cancers. The median age of diagnosis and mean age is 60. So I'm going to briefly describe a case I just saw yesterday that was a 62-year-old female who had an endometrial biopsy that showed clear cell fragments. She had a THBSO with sentinel lymph node assessment, and her uterus had clear cell carcinoma that measured 4.5 centimeters. It invaded 45% of the myometrial thickness. There was no LVI, and lymph nodes were negative. So what do we do for her? Well, and how do we understand her disease? There's a Taiwanese GOG study that compared pure clear cell to mixed clear cell. And what they found, stage for stage, was that the numbers of patients that were in each stage were relatively similar, whether it was pure or mixed. When they looked at survival, they also found that the percent of clear cell involvement was really not prognostic. What was, however, significantly prognostic was the stage. So stage 1 patients fared significantly better than patients with other stage disease. As you can see, stage 2, 3, and 4 listed on the curve are statistically significant in terms of worse overall survival. Patients received a hodgepodge of treatments, with 27% receiving no therapy in the adjuvant setting, 21% receiving radiation alone, and another 21% receiving radiation in combination with chemotherapy. The NCCN guidelines for patients with stage 1 disease indicate that the treatment for a stage 1 or 1B would be to consider chemotherapy and radiation, or radiation alone. In this particular case, the patient chose to receive vaginal brachytherapy and was not interested in receiving chemotherapy. We did not have a strong sentiment that that would be of benefit to her because of the chemo-resistant nature of clear cell carcinomas. Now again, if there are positive washings, there's always a question whether systemic therapy may be better. But again, we have no evidence that chemotherapy has activity in this disease. There is evidence that brachytherapy has a role. There are retrospective series, this one from Mayo Clinic with 21 out of 103 women with clear cell carcinoma. Patients received vaginal cuff brachytherapy, and 5 also received platinum-based chemotherapy. And the 5-year disease-free survival was 87% for clear cell cancers, and 5-year overall survival 83%. The 5-year rate of extrapelvic relapse was 16%, and 2 patients had a vaginal cuff recurrence. They conclude that vaginal cuff brachytherapy was really sufficient with no need for additional external beam radiation. The NCDB publication looking at 2004 to 2015, 22% had clear cell carcinoma, and they found that for all stage 1A patients, there was a 3-year overall survival advantage, 87% versus 78%, that was statistically significant. And when they broke it down by no myometrial invasion versus myometrial invasion, they found that there was statistically significant survival benefits for vaginal brachytherapy in both groups. So really there was no population that did not benefit. So even with no myometrial invasion, vaginal brachytherapy is recommended. When looking at the molecular profiling of clear cell, we see that this is a study of 52 patients with a median follow-up of 3.4 years. And they found that patients that had molecular categorization of having POL-E mutation or mismatch repair deficiency actually had 100% overall disease-specific and progression-free survival. Those that fared the worst had P53 abnormalities, and above that, the green line is P53 wild type. So we know in this population that POL-E mutations in an endometrioid population, POL-Es fare very well, and in this group, MMR deficient patients also do. We have very little data on what chemotherapy works in uterine cancer patients with clear cell. There was a recent publication at ASCO on advanced clear cell carcinoma of the ovary, and it showed that patients with bevacizumab treatment had a significant improvement in overall survival, with a median OS going up to 51 from 34.7 months, and a median PFS statistically significantly increasing and more than doubling to 29.7 months versus 12.5 months. Is poor prognostic feature, and we see that it is, in addition to P53, P16, and P21, and beta-catenin, one of the features that is correlated with a poor prognosis, as shown in the graph on the right, where you see the 5-year overall survival of 85% with ARID1A positive versus 60% with ARID1A negative cancers. We can target ARID1A through various treatments, through either PI3 kinase, mTOR inhibitor, through immune checkpoint blockade, upregulation of MERP2, or through DNA damage response. And we are obviously talked just now about. I did want to mention, just because I've seen several cases of clear cell carcinoma of the cervix, which we manage as if it were a non-clear cell. We do not give additional chemotherapy given the sensitivity, but we notice that these patients can present with very large primary cervical masses and can be in a very young patient population. So we know that we need more extensive genomic characterization of clear cell carcinomas of the uterus, cervix, ovary, and others. Generally, clear cell has been treated like serous cancer, but it really isn't. It's much more heterogeneous and much more resistant to therapy. What we do know is, can we tailor treatment to the molecular subtype? Even for clear cells, it looks like POL-E mutated patients may not need any adjuvant therapy, whereas P53 abnormally mutated may be the ones that benefit the most from chemo. Of course, that optimal treatment is not known, radiation or immunotherapy may actually be of benefit. Whatever is effective will need to be studied and advanced in future trials. These are some of the trials which are looking and have looked at clear cell carcinoma. These include sunitinib, paclitaxel and temsirolimus, cabozantinib, and dasatinib. But these are all most negative. So it may be that there's another type of treatment that could potentially work, as I mentioned, population. Now I'm going to switch gears for the next 5 minutes and talk just about mucinous adenocarcinomas. I'm going to focus more on the cervix because this is a type of cancer that I see. And it does have an extremely poor prognosis. It is not associated with HPV. There are different types. Some call mucinous adenocarcinomas adenoma malignum. They're well differentiated. Others call them gastric type invasive carcinoma, particularly when they're less well differentiated. But it does have a tendency to metastasize early to fallopian tubes, peritoneum, pelvis, lymph nodes, and distant mets with a 5-year survival rate for all comers of about 30%, with most patients relapsing within the. There was recently a study on the molecular profiling of gastric type invasive adenocarcinomas of the cervix in 15 patients. 100% of these patients had MUC6 positivity. P16 was positive in 87%, and P53 was mutated in 53%. As you can see from the table on the right, the list of genes on the right, and that might be too small for you to see, but STIC1 was more frequently identified in well-differentiated and LVI positive patients. Other common mutations were CDKN2A, ARID1A, P10, ERB2, CDK12, and KRAS. There is inherited gastric cancer gene called CDH1, and I have treated a patient that had a CDH1 positive diagnosis, had a gastrectomy, and then ended up with a gastric type invasive adenocarcinoma of the cervix that was CDH1 mutation positive. So possible, but much rarer, and in general, these are genetic predisposition. When comparing the clear cell mucinous adenocarcinoma profile to the endometrial TCGA overall, you can see that from the mucinous adenocarcinoma graph that we just saw, there is similarities in overall P53, ARID1A, P10, CHIK2, and cyclins being mutated in the copy number high subgroup. Just a quick case, a patient that I saw 2 weeks ago now presented with abdominal heaviness and discomfort, and a CT showed a 14 centimeter cystic mass. She had a general gynecologist do a simple hysterectomy, but there was spillage. Path ended up surprisingly showing a microscopic tumor, 7 by 4 millimeters, depth of invasion 4 millimeter, of an endocervical gastric type adenocarcinoma with bilateral ovarian involvement. So a very small primary tumor, but large ovaries that looked metastatic. She was treated with post-op RT. The patient ended up refusing initially concurrent chemo, but she did end up getting Outback Carbotax after much debate. 3 years in follow-up, she is now NED. Emphasize for all patients that have locally advanced disease to follow standard practice patterns. That is, if there's a locally advanced cancer of the cervix, whether it be adenoma malignum, and the patient is deemed inoperable, please do brachytherapy because it improves overall survival. Specific dose constraints when doing brachytherapy to make sure to be safe and prevent fistula. We'll use imaging, particularly MRI, but even CT is better than no imaging at all. And that's just a plug because it's something I did bring up some astro slides for I think most know these points, but just to say that the delineation of what's operable versus inoperable is generally made based on cervical cancer stage, and this would again pertain to mucinous adenocarcinoma of the cervix. We would, as this ASTRO guideline does show. So for postoperative treatment, we consider high-risk features. Now, because of the histology, that would be included as a high-risk feature, so all patients postoperatively would get external beam and in the study, and we do recommend IMRT to decrease both acute and chronic toxicity in all cervical cancer cases, whether post-op or recommend brachytherapy for all intact cervical cancer cases, and then conditionally recommended in the setting of close or positive margins for those patients who are treated with postoperative whole pelvic radiation. And fractionation is just briefly shown or described in the paper itself. We do recommend MRCT-based plan operatively, and the ideal dose for intact cervical cancer should be greater than or equal to 80 gray to the D9. We use volumetric contouring of the organs at risk and of the tumor whenever possible, given the limitations of 2D point-based brachytherapy. Doses. And this is just the standard advanced disease, and again, the planning goals that I just. So the key takeaways from the ASTRO guidelines were described much in the paper, but we do always do concurrent cisplatin-based chemotherapy. We do not recommend induction chemotherapy or adjuvant chemotherapy, but we do recommend doing brachytherapy, and we recommend image-guided brachytherapy preferably. New horizons will include immunotherapy agents and other therapeutic classes. So I thank you very much for your time and appreciate the invitation to speak with you today.